to show the importance of it. Yeah. Only slides. Fine. So, as I told you, the first thing that you should, when you go from here, and I want you to learn and go, is it's a teamwork. So when you initiate, it has to be properly planned initiation. Okay. So I always divide it into 3 steps or 4 steps. One is a team preparation, that is most important. Second is your relatives preparation, again that is most important. Third is a circuit preparation, and fourth is the patient preparation. These are the 4 steps which are very important when you initiate patient on ECMO. Okay. Team, everyone knows what is their role, what is the goal we want to achieve, what is our strategy is. So that has to be, everything which to be planned. So initiation starts before you actually cannulate the patient. All planning has to be done before, and everybody should know who is going to do what. Okay. Relatives preparation is again important, counseling and consent. Circuit preparation, that we already told you how to select the circuit and how to prime the circuits. And patient preparation. This is usually an ignored one. Okay. What happens when you see patient is going to ECMO, and especially when you are doing a new ECMO centers, everybody jump towards an ECMO. And everybody see how ECMO is getting primed and how we are going to do everything. And patient is ignored. So that is most important. You should always remember patient preparation is most important. And you have to prepare the patient for in terms of volumes, inotropes and ventilation. And whether patient requires any surgical procedure or no. Cannulation and heparinization, that is again an important part. Okay. So you require at least 3 teams or 3-member role. One will help in cannulation. So everybody should know their role. The one who is going to help in cannulation, it is his responsibility to counsel, to take the consent and take all logistics cleared, administration and everything, all logistics. The one who will take care of circuit will take care of priming, selection of circuit and blood products. Okay. That is the role of the second person. Probably it might be your ECMO specialist or might be your perfusionist or ECMO trained nursing staff. So they will take care of that part. Okay. And third, one team should look after the patient. So they will look after the whatever injectables to be given and emergencies. So whether to give fluids, ventilate the patient, resuscitate the patient, heparin bolus, all that responsibility goes to the third team. So always in next 2 days and even in your practice, whenever you have been given any scenario, first divide yourself into 2 or 3 teams. Okay. One is going to look after ECMO, one is going to look after patient. Okay. And if it's initiations there, one is going to do cannulations always. Okay. So when you initiate, you have to adjust the parameter. As I told you, you have to just adjust the RPM, increase the RPM so that you can increase the flow, glow slowly. So first, when you initiate, you have to increase the RPM to 1000 because this is a centrifugal pump. This is a non-occlusive pump. So if you don't increase the RPM first and you release the clamp, what will happen? The blood will move in the reverse direction from high pressure to low pressure. So you have to always keep the line, return line clamped when you initiate VA or VV ECMO in centrifugal machine. Okay. Don't do that with a roller machine. Otherwise, I have shown you the picture what happens. So in a centrifugal machine, keep it clamped. Okay. Increase the RPM to 1000, then release the clamp. Okay. Look at the colors. Get the target saturations. Okay. And go to the rest ventilator settings. These are the steps you need to follow. Now, I am showing you the video. What we are doing is, the patient is cannulated. We have connected the circuit, venous line to drainage line to the vein, return line to the artery. I am just connecting the flow probe. You can see everything is connected. It's a blood primed circuit. Okay. You see RPM is 700, but flow is 0. It means it is the return line is clamped yet. In VV ECMO, you can increase the RPM to 700 and can release. In VA ECMO, you have to always increase the RPM to more than 1000. This is the parameters before we initiate ECMO. Okay. So you can see saturation, hematocrit, BP is around 86, heart rate is 130, saturation is around 90, and with the ventilator settings of FI to 100%, peak pressure is around 45, 48. Okay. This is the ventilator setting with which we initiate ECMO. Okay. Fine. Okay, now see, This is all connected. Now I'm just releasing the clamp. I've just released the clamp. Can you see the dark color drainage and the bright red color return line? The first thing you should always look at is the color difference. The dark color and the bright red. It means if both the colors are different, it means everything is fine. If both the colors are same, then you are worried. Okay. Yeah. If both are bright red, it is recirculation. If both are dark, it means your oxygenator is not working. Okay. Fine. Again, this we'll discuss when we go to the stations. Yeah. And now see, with 1000 RPM, you can see 1.7 liters of blood flow. Okay. Now this is again possible when with a Sorin machine. If it is a mid-hole machine, you will not get flow. So again, that depends on the machine to machine. Okay. Now see how much sweep gas I kept? Only 800 ml. So when you initiate ECMO, see CO2 is highly diffusible gas. I told you in my talk also. You should always remember, especially when you are doing VV ECMO, when the patient's CO2 is high, say to start with more than 60, 100, 120, 150, get the CO2 down gradually. Otherwise, sudden decrease in CO2 level will cause the neuronal injuries. Okay, it can give rise to, it's just the capillaries are hypoxic. So there is some petechial hemorrhage that can occur because of that. So you can have an increased risk of bleed, IC bleed, if you correct the CO2 fast. The recommended is 14 mm of Hg per hour. That should be the recommended rate, not more than that. Okay, 10 to 14 mm per Hg per hour. It should be the correction rate. Should not be faster than that. Okay, so that you should always keep. So keep sweep gas low, half the blood flow rate, and then gradually increase. So suppose your blood flow rate is 1 liter, keep it 0.5. Suppose your blood, when you increase the blood rate flow to 2 liters, increase the sweep gas to 1 liter. If you go to blood flow rate to 4 liters, increase the sweep gas to 2 liters. Okay, and grow gradually. And then suppose your CO2 levels are still high, then you can increase the sweep gas to 1:1. So you can make 4 liters and 4 liters. But that depends upon looking at the ABG report. Okay. Now see, after starting, this is the pre-pump pressures, what you can see, -15, -17. Okay. Okay. Saturation has gone up to 97. Now I have decreased the ventilator setting, so it has come down to 88, and that is what you have to titrate. Okay. So once you reach the targets, come down on the ventilator settings because you want to do a rest ventilator setting. So I am now on rest ventilator setting. FiO2 has come down to 40. Gradually I will still further come down. Okay. The peak pressure is restricted to 26. Okay. Tidal is 170 and it must be around 60 kg weight. Okay. This is what we do. We connect, suppose we don't have a monitor, we used to connect this in a one single monitor with the 3 ways. So we keep pre-pump pressure line open, so we monitor pre-pump continuously, but pre-oxygen and post-oxygen line, we keep it every hourly we check the pre-oxygen and post-oxygen, and thereby we can check the delta pressures. The RPM 1900, with that the flow is 4.6 liters. Again I said this is Sorin and Medtronic, you can see this. Not even Mackay, you don't see such a difference. Okay. Sweep gas have increased to 2 and FiO2 is 100%. Okay. So when you monitor, you are monitoring 2 things. One is native circulation and one is ECMO circulation. So you have to monitor circuit as well as patient. Okay. Monitoring, why it is important? Because there are certain complications which makes ECMO to stop, and when patient is ECMO dependent, if it stops suddenly, if you are not prepared, then you have a problems. For an example, suppose oxygen gets blocked completely. So you are off ECMO totally and patient lungs are not working. So it's something like we are doing is asphyxia, isn't it? There is no oxygenation from the lungs, there is no oxygen from the outside. And then you take another oxygenator, you prime the oxygenator and do it, it will take on some time. So the patient may not give that much time. So you have to be worried about that part. Okay. So monitoring for adequacy as well as safety. I already discussed this point. I think I already discussed this slide, so I'll just keep it. So circuit check, look at the cannula, look at the connectors, check for the clot, check for the kinking, auscultate the pump, look at the alarms. Okay. This is Rotaflow 1, and I think now it will change to Rotaflow 2. But you might get some signal alarm. Signal alarm is because the gel for the flow sensor is less, so in that case. But now in Rotaflow 2, it is not there. So, okay, this is the noise. I will not see, able to see this. here. Let me skip this because you will not be able to hear these sounds. Okay. This is the, you can see the clots in the oxygenator. You can look at the blender. Okay. Return side as well as venous side and arterial side of the oxygenator, you have to look for the clots. You can see some fibrin deposit on venous side. There is no deposit on the arterial side. Why this is more important is, if it is an arterial side, you are more worried because it will go to the directly to the patient. If it is a venous side, you might even accept it if other parameters are fine. So you have to be very mindful. If it is arterial side, you cannot accept it. If it is venous side, you might be able to accept it. So look at both the side, venous side or arterial sides. Okay. Look for the color difference. If both are same, it means recirculation. Okay. I told you P1, P2, P3 monitoring. Okay. So P1 is a negative pressure always. So whenever you see, P1 is always negative. It is a suction, so it is always a negative pressure. Okay, remember. If it is positive pressure, you have to think why it is positive. Okay. So it is usually a negative pressures. Causes of negative pressures can be your cannula size can be small, your flow requirement is very high, patient is hypovolemic, or your cannula is not placed properly. So you might get too much of negative pressures. So you have to always look after, if the negative pressures are too much, you have to think about all this. Okay. If the negative pressure is at more than 200, it will cause hemolysis. Usually in adult patient, we accept negative pressure up to 20 to minus 70. Minus 20 to minus 70. If it is more than minus 70, the risk of hemolysis will increase. Okay. And the vessel will get stuck to the cannula and then will be damage to the cannula. The vessel wall. The pre-oxygenator pressures, you measure it before the oxygenator. Anything which causes increase in the afterload will increase the pre-oxygenator pressure. So anything after the pump, okay, if the resistance increases, whether it's the pump or whether it's a oxygenator or tube or cannula, return cannula, anything if the resistance increases, the P2 will increase. Okay. So in PA, as the arterial side, the resistance is more, so you have more P2 in VA as compared to VV ECMO because the resistance is less. The systemic vascular resistance is less in veins as compared to arteries. So your P2 level will be more in VA ECMO and it's going to be less in the VV ECMO. Okay. All factors are same for post-oxygenator also. Anything after the oxygenator is going to get kink or something, your P3 level also will increase. Okay. Anything goes wrong in the oxygenator, the P3 will decrease. So P2 will increase and P3 will decrease if there is something wrong in the oxygenator. Anything wrong after the oxygenator, both P2 and P3 will increase. So that you should keep in mind. So anything goes wrong with the delta pressure, it means something wrong with the oxygenator. If both are increased, something wrong after the oxygenator. You should keep this in mind. Okay. I think this I discussed. RPM and flow ratio is very important. You should always keep that in mind for two reasons. One is, suppose your machine stops, you know how much should be the speed. Second, you should know how much is the RPM and flow. Because as I told you, flow depends also on preload and afterload. So the same RPM, suppose your flow decreases, that means it is directly proportional to the preload. Means if the same RPM the flow decreases, it means there is a decrease in the preload, or there is an increase in the afterload. It is inversely proportional to afterload and directly proportional to the preload. So the preload increases, the flow will increase. Preload decreases, the flow will decrease. Similarly, if the afterload increases, the flow will decrease, and afterload decreases, the flow will increase. So that you think you have to keep in mind. So it depends on the preload and afterload. So same here. See, can see with the 4100 RPM, the flow is 5.9 liters. With the same RPM, the flow is decreased to 4.6 liters. It means there is something wrong. Either there's something wrong with the preload or something wrong with the afterload. So these numbers you should always keep in mind, the relations. Okay. Okay. Then gas flow rate, as I told you, you have to get the CO2 down gradually. So this is how you can adjust your sweep gas. Okay. Most of the time nothing happens, but then once it happens, you had it. Okay. Now I am showing you the importance of circuit pressures. Okay. Just a minute. Yeah. So now this is a young patient of around 25 years, dengue ARDS, and was put on ECMO, and this was day 14, 15 of ECMO. You have to just see the parameters of what I'm showing you. I hope you have shown the parameters, initial parameters. Can you see these parameters? Keep these numbers in your mind. With the 2400 RPM, your flow is 3.1 liters. Now this is Sorin machine, which is something which makes you disturb. You know, you should have a VV ECMO, Sorin machine, 2400 RPM, the flow should have been better, more than that. But that's keep this in mind, these numbers. Okay. Sorry. Okay. So this is RPM and flow ratio. If you see, now if you see the data, this was a young patient where this patient was put on VV ECMO for ARDS. Okay, he was doing well. This was day 12 or 13 of ECMO, and he was doing well. You are not able to see the pre-pump pressure. So pre-pump pressure has gone very high. This is the post-oxygenated pressure, which is around 150. Okay. So the delta pressure was somewhere around 300 in that patient. Okay. The patient's delta pressure was gradually keep on increasing. We were about to wean the patient from ECMO, so we thought that if we can pull on for some time. See, if you can see the saturation is still 94 with the 3 liters of flow. So he was doing well. So we thought that we might be able to just get rid of it. So we were just delaying change of oxygen, because again change of oxygen will be an additional cost, and the family was not that well to do. So we need to thought of that we can avoid it, but then probably the time didn't permit us, and the patient started going into hemolysis, and he started having a hematuria and hemoglobin urea and that. So we have to think of we have to think that we have decided that now we have no alternatives, we have to change the oxygenator. So now this is the steps we are changing the oxygenator. We are clamping, double clamp method. Again, this I am going to show you in the evening. So I just, in the interest of time, I am just keep this part. Okay. So we are just changing the oxygenator. We have cut the new old oxygenator out. We are just putting the new oxygenator with air-free techniques. Okay. See, because he was stable patient, his lungs were improving. He is still maintaining saturation of 87, in spite of we have kept the flow stopped. Otherwise, if the patient is not stable, then probably it will go down drastically. And saturation goes down very low, and patient can develop even bradycardia and cardiac arrest. But now we have ample of time because patient is on the recovery side. So lung is contributing significantly, so we are not much worried about it. So it has to be de-aired properly. Okay. I'm not able to fast forward it, thus I will do fast forward it. What important part I want you to understand is, this is connected, one side is connected, we are now connecting the other side. This is a new oxygenator, we are connecting the other side. So these are both important steps, how to hold the tube, how to hold the cannula, and how to pour the saline. That is all important, so that you can remove the air easily and you can have air-free connections. Okay. Now see, the clamp circuit is clamped with same 2400 RPM. Okay, initially it was 3.1 liter flow. Now circuit is still clamped, so flow is 0. And see the flow. The same RPM, the flow is now 5.8 liters. Okay, so that's the importance of monitoring the delta pressure. If we would have still further delayed, the oxygenator would have stopped completely clogged, and the ECMO would have stopped suddenly. Okay. And then when we have checked the pressures, circuit pressures again, the circuit pressure was, delta pressure was 70, 150 was somewhere, 140 to 150 was a pre-oxidative pressure, and another was 70 pressure. So I'll just skip that video. Okay. So this is, then we have, what we have done, we have decreased the flow. Yeah. So we have decreased the flow RPM 1600 and kept the flow around 3.5 liters. Okay. So this is the patient related monitoring. All of you know, look for the tachycardia. Usually once the patient put on ECMO, the tachycardia should settle. If still tachycardia persists, you should think about it, because you are correcting the cause, hypoxia, hypotension. So tachycardia should settle. If not, you have to think about the cause, okay, what can be the cause for tachycardia. Okay. Asynchronous breathing with ventilator, always you have to sedate the patient if required. Monitor the mean artery pressure, monitor the pulse pressure in case of VA ECMO. Temperature is required because hypothermia can give us a lot of other complications, you know. And the blood is moving outside the body, so hypothermia chances are high in this patient. Okay. You have to be maintain minimum 10, otherwise patient will go into cardiac stunning. Okay. So there has to be some ejection from the heart, otherwise it will be cardiac stunning. Okay. So pulse pressure you have to monitor, it has to be around 10 at least. Okay. Look for the limb perfusion, limb colors. See, ECMO flow is a continuous flow. Okay, so there won't be a systolic and diastolic variation. As I told you, VA ECMO is a parallel circulation. So when you take more of the blood on ECMO, it means you have more of a direct flow. Your systolic and diastolic contraction will decrease. Okay. Now, at the same time, you are increasing the afterload on the heart. See, ECMO is good for the preload, but it's bad for the afterload. So when the heart is diseased and you are increasing the afterload, the cardiac contractility will still goes down. And there is something known as cardiac stunning which occurs. The heart ejection, which was 10% or 15%, will further go down. Okay. So that can be assessed with the help of pulse pressure. If the pulse pressure goes down less than 10, it means patient has developed cardiac stunning. And if this cardiac stunning continues for a long time, okay, it will cause LV dilatation and then cause back pressure changes, pulmonary edema, and there is because the blood remains stagnant in the LV, is not ejecting, so that will develop some thrombus in the blood. And this LV, once it starts dilating, it becomes an irreversible LV. Then you don't, this LV does not recover. So in that case, you have to always be mindful about pulse pressure. Pulse pressure 10 or less than 10, it means patient is going towards a cardiac stunning, and you have to take care of cardiac stunning. We'll discuss how to manage cardiac stunning in futures. Okay. Okay. So this is a limb perfusion. You have to look for the limb color and cannula site. These are the investigative protocols which we follow. Again, that varies from center to center. There are centers who can do ABG4 hourly also, CBC twice a day, but we don't follow that stringently. Okay. For a VA ECMO, this is most important. See the Doppler and see the how the flow is in the periphery. Okay. You can see a popliteal with the help of echo machine, or you can use a IBP probe, Doppler probe, for a posterior tibial or anterior tibial vessel. Okay, that's it.